Alrighty, so welcome to the Thyroid Crash Course, part of the Rokai Therapeutics review sessions. So pretty much this is just kind of a overview of what this guy right here talks about in his lecture. It's kind of just the finer points of the lecture. I didn't really want to do a deep dive on it, but I did try to kind of go slow and explain stuff. So I would definitely recommend for those of you that are trying to cram before the exam, this is definitely one you can listen to on double speed. I tend to talk a little bit slow so that you really can kind of process the information. So I'll post this as just kind of a supplemental resource for you guys to kind of go through. And then I will also post a variety of questions that we can work through that Sunday, the day before the exam, so that you guys really kind of are best prepared for your exam. So we'll get into everything you would ever want to know about the thyroid, and hopefully this will help you guys out. And I provided my email right here in case you guys have any questions throughout the process. Alrighty, so let's get started. As far as objectives go, we want to know who needs therapy and what agent do they need. Robo loves dosing. So really have a nice idea of what we should dose patients at and kind of those tables and charts that lead you the way there. And then also, I would expect a lot of case-based stuff to try and figure out, what Graves therapy works best for a specific patient. Because it really can be on a patient-by-patient basis, and you need to have an understanding of that. So these are the objectives, and now we'll kind of get into a good overall explanation of everything that Roble talked about. Okay, so when we talk about kind of classifying hypothyroidism, we kind of classify it based on whether it's overt or whether it's subclinical. So both of them have increased TSH. Both of them have that going on. But in overt hypothyroidism, the FT4 is decreased, whereas the FT4 is normal in subclinical. So this is a kind of a good differentiating factor between the two. And then when we talk about symptoms, both of them can kind of have symptoms or not have symptoms. Okay, so who do we actually treat for hypothyroidism? So we want to treat everybody that has overt hypothyroidism. We also want to treat anybody that has subclinical hypothyroidism if their TSH is over 10. And why is that? It's basically because people with these levels have a greater risk of CV events, and then they also have a higher chance of going to overt. So then another class that we basically always treat is we always want to treat pregnant people or patients that are looking to become pregnant if their TSH is over 2.5 and they have positive TPO antibodies. Okay, so we touched on, who do we definitely treat in that past slide, but who do we kind of treat maybe in wishy-washy scenarios where we're not necessarily sure if we want to treat or not? There's two big ones. So one is subclinical if the TSH is between 4.5 and 10. and they have other stuff like signs and symptoms of hypothyroidism. They might have positive TPO antibodies. They might also have CAD or congestive heart failure or other risk factors that are associated with it. Another kind of wishy-washy one where we might treat, we might not treat is if a patient's pregnant or planning to become pregnant and they're not hypothyroid and they meet certain TSH criteria based on what trimester they're in. So when we look at this a little bit deeper, so if they're in the first trimester or they're planning on becoming pregnant, if that TSH is anywhere from 2.5 to the upper limit of normal, which is around 4, then we might think about treatment. When we move to the second trimester, if that TSH is anywhere between 3 and the upper limit of normal, then we might think about treatment. And then when we move to the third trimester, if that TSH is anywhere between 3.5 and the upper limit of normal, we're definitely going to be thinking about possibly initiating treatment. So when we actually decide to treat patients, what are our goals of therapy? So there's three main goals, and obviously, it gets a little bit more specific when you talk about specific populations like pregnant people and elderly patients. But these are kind of the three big main things that we want to keep in mind. So we want to try and get patients to be biochemically euthyroid, so basically get them back to normal levels. We want to try and improve any symptoms if there are symptoms present. And then big thing is we want to try and avoid oversupplementation in the elderly. This is a big problem where, every 80-year-old grandmother, it seems, is on levothyroxine. And this is especially troublesome because it can lead to thyrotoxicosis, which is obviously not good. We don't want that. And we just kind of have to keep in mind that in the elderly, subclinical thyroid may just be a function of aging. So I thought it'd be important to cover what exactly thyrotoxicosis is, because we really talk about it a decent amount in both aspects of this lecture. So thyrotoxicosis is basically a manifestation of the thyroid hormone basically just running rampant. It's just kind of doing too much because the TSH is too high. And so signs and symptoms of this, common ones are weight loss, fatigue, palpitations, and tremor. Big one and pretty easy one to spot would be goiter. So the thyroid looks enlarged. This is typically how it gets noticed in a lot of patients. And so this is basically just a quick overview of thyrotoxicosis. So kind of jumping to a specific population. So when we're treating pregnant patients, we generally want to have lower lows and lower highs, and obviously referencing TSH levels. Also with pregnant patients, a nice kind of thing to just be mindful of. If a patient is pregnant but they're euthyroid, but they have positive TPO antibodies, we don't really want to treat them because it's not beneficial. So what drugs do we actually use to treat hypothyroidism? So the first one that you could use if you really wanted to is desiccated thyroid. So this one, as Robo likes to talk about, is basically derived from pig thyroid, which is pretty fun. And so basically with this one, what you need to really remember is that the proof of efficacy just really doesn't exist. It really just doesn't do a ton based on the studies that they've done. But it could be useful for patients that want kind of a natural product. So the typical example is that Robo gives is like the soccer hippie mom. So that's kind of a way to remember it. So the next medication I want to take some time to go through is liothyronine. So this one is basically synthetic T3. And because it's T3, it works a lot faster than T4. But kind of subsequently, it's going to have a short half-life. And when you get a short half-life, you have to dose it more frequently. So this one typically is dosed BID, which really isn't very convenient. There could be other options that we'll get to in a sec that might be a little bit better. So kind of the bad associated with liothyronine is that in patients with cardiovascular like comorbidities, it's not really good for these patients because it could increase the amount of cardiac toxicity that these patients experience. So we don't want to give it to patients with cardiovascular stuff going on. Good things behind liothyronine is that it can be useful in life-threatening situations. So if a patient comes in and has life-threatening hypothyroidism, this would be an agent that we might want to use because, like we talked about, it works fast. It works quickly. So it can get a person back to normal quicker. Okay, so we're saving the best for last here. So last drug is levothyroxine. So if you work anywhere, I'm sure you've seen this a bajillion times. This one is prescribed to everybody and their mother. So it's basically a T4 analog. So it's going to work a little bit slower than liothyronine, but it's going to stick around for a little bit longer. So we can actually dose it daily. and the half-life is like 7 days. It comes in a wide variety of dosages, anywhere from 25 micrograms all the way up to 200 micrograms. And it's really easy. This is a big plus of it. It's really easy to kind of dose it and titrate it if you need it. So you get a TSH level back, and you're on 100 micrograms, you can bump right up to 112 micrograms. Another point with levothyroxine, and this is more so in the inpatient setting, but if you're switching from PO formulations to an intravenous formulation, you're going to want to decrease the dose by about 50 to 75%. That's just kind of in the inpatient setting. What I more so focus on is that levothyroxine is drug of choice in hypothyroidism. It's easy because it's daily, and there's a lot of dosages available, so we can really kind of mess with upping the dose pretty easily or decreasing the dose easily if we need to. Okay, so if levothyroxine is our number one agent for treating hypothyroidism, we really need to know how to treat it. So I like to break this up, and this is kind of how Robo breaks it up as well. So we want to classify based on overt or subclinical, and then once we've kind of divided that up, we can further differentiate in the overt hypothyroidism. So remember, these patients have increased TSH and decreased FT4. And so these patients, if we classify, we look at young and healthy patients under the age of 65. We're going to start these patients out at 1.6 micrograms per kilogram per day. And you need to remember that it's ideal body weight. So we dose by ideal body weight in this situation. Don't get tripped up by that on the exam. It will happen. So then if we look at old and healthy patients, so they're over the age of 65, but they're relatively healthy, we're going to start these patients out at 50 micrograms per day. And then if they're overt and they have known coronary artery disease, we're going to start them out at a dose of 12.5 micrograms to 25 micrograms per day. And whether you pick 12.5 or 25 typically depends on the specific patient. Okay, so that's overt hypothyroidism. What about subclinical hypothyroidism? So in his notes, Roble talks about how we really want to avoid treating subclinical unless there's a compelling argument for it. And we've kind of already discussed patients that we would think about treating when they have subclinical hypothyroidism. In your notes, I didn't necessarily see anything about treating and what the dosages are, but just so that you have it in the back of your mind, it's typically 25 to 75 micrograms per day when we do decide to treat. And basically, if the TSH is basically a value between the upper limit of normal and 8, we would do 25 micrograms. If the TSH was between 8 to 12, then we would do 50 micrograms, so kind of meeting in the middle. And then if the TSH was over 12, we would go with 75 micrograms a day to start out. So what's our treatment timeline with levothyroxine? So we're going to initially start therapy, and then we're going to want to check the TSH about 4 to 6 weeks after starting therapy. And the next question we want to ask is, is the TSH within normal limits? So what do we do if it's not within normal limits? So let's say that the TSH is a little too high. So what do we do then? So in this scenario, we're going to increase the dose because we need more effect from the levothyroxine. And we're going to increase it about 12.5 to 25 micrograms based on, how high it was. If the TSH comes back low, then that means that we maybe need to bump down the dose a little bit. So we're going to decrease, maybe 12.5 to 25 micrograms. So that's what we do if it's not within normal limits. But what do we do if the TSH is within normal limits? So that basically means that, we're doing a good job. We're doing all right. So from there, we're going to check the TSH every 4 to 6 months now instead of weeks. And from there, we can check it every year, or if there's a good reason. This could be from drug, disease, weight, or pregnancy. Levothyroxine drug-drug interactions. And based on Robles' slides, there's really only two that I would really focus on. One is lithium. That's one drug-drug interaction. And then another one is amiodarone. So if you notice, I've kind of highlighted the IOD here. And that's because amiodarone leads to kind of an increase in our daily iodine intake, which therefore kind of ramps up thyroid production, which can kind of cause trouble when it comes to levothyroxine, because it's basically messing with what levothyroxine is trying to do. So with levothyroxine, there's just a couple tidbit points that I wanted to mention. So we want to counsel patients to take this one with water and to not co-administer it with any other medications. We also want to tell patients to take it before breakfast, and we want it to be 60 minutes before breakfast. Or we want it to be about 3 hours after dinner. And this is really important because otherwise you might be limiting the dose that the patient is actually getting into their system. We should also counsel patients that this medication really shouldn't be used for weight loss, and they're probably going to be on it for life. It's not really a therapy that really gets taken away all that often. So every medication has side effects. So what are levothyroxine's side effects? So it can cause alopecia, aka hair loss. People can also have allergies to the excipients that are in the tablets. And then also we can get iatrogenic thyrotoxicosis. So this one is basically caused by healthcare professionals, aka us and physicians, basically caused by giving patients too much levothyroxine. So as we kind of discussed earlier, we want to be mindful of this in the elderly and make sure that we're not over supplementing them. Okay, so now we're kind of shifting gears. So we were talking about hypothyroidism. Now we're going to focus on hyperthyroidism, also called Graves. So what does this condition look like? So as far as symptoms go, one is pretibial myxedema. So that's basically clubbing of the fingers or the feet. A quick Google search will show you kind of exactly what I mean by this. When we look at another symptom would be vitiligo. It's basically where you lose pigment in the skin, and it looks kind of patchy almost. There's a famous model that has this condition. And then another symptom would be, and this is pretty hallmark, a lot of patients will present with this. It's Graves' ophthalmopathy. And if you've ever seen Caddyshack, Rodney Dangerfield is like textbook for having this. Okay, so what about signs of hyperthyroidism? So we can look at thrill. So that's basically kind of vibration without talking. And then systolic bruit over the gland, so over the thyroid gland. It's basically like swooshing from turbulent blood flow over that thyroid gland. And then another important thing is tachycardia is a pretty common concomitant presentation, and so we want to be mindful of this. So we talked about how tachycardia can be a pretty big concomitant thing with hyperthyroidism, and we want to give something to help with that tachycardia. So one agent that we can use is a beta blocker. So let's use propranolol. It's the most commonly used beta blocker in this clinical picture. So who should we give propranolol to? We want to think about it in patients with a resting heart rate over 90 We want to think about it in elderly patients, and then we also want to think about it in patients with cardiovascular diagnoses. So that's one subset of patients that we should think about giving propranolol. Another subset of patients is all patients with symptomatic thyrotoxicosis. And why that is, this helps with the beta blockade. So it helps with these effects up here, the heart rate, and helping bring all that down. But what it also does is it limits the conversion of T4 to T3. So why this is helpful is because T4 is less potent than T3. So it basically helps prevent thyrotoxicosis because we want this T4. It's a little less cumbersome than the T3. So rule of thumb, propranolol for all patients with symptomatic thyrotoxicosis. So how do we treat hyperthyroidism? So there's three main modalities through which we can do this, and we'll really kind of dive into each one of these in greater detail in just a second. So we've got the anti-thyroid drugs, so we could use a thioamide like methimazole. We've got radioactive iodine, and then we've also got thyroidectomy. So we're going to go into each one of these guys, and we're going to cover factors that might favor this option, contraindications to this option, and then kind of patient preference. So why would a patient want to do the anti-thyroid drug versus radioactive iodine? So let's cover anti-thyroid drugs first. So factors that kind of predispose us to thinking that this might be a good idea for the patient. If it's relatively mild disease, might be a good idea. Also, if they're at increased surgical risk, might not be a good idea to go that route. Might be better to just give them this oral therapy. Also, if patients have limited life expectancy, maybe they're 85 years old and they're nearing the end of their life and they'd rather just go this route. This therapy is also good for patients with moderate to severe active Graves' ophthalmopathy. So once again, we think of patients like Rodney Dangerfield, who just have eyes bugging out of their head. Might be a good idea to start therapy this route. Also, factor would be, is the patient from like a rural community where they might not have access to a surgeon who wants to perform this? And then also if they've had like a neck operation in the past and we don't necessarily want to go that route again. When we talk about contraindications to this type of therapy, basically if they've had a previous known reaction to an anti-thyroid drug, we don't really want to mess with that again. Then when we talk about why would a patient want to go with this therapy, so pretty big value on they don't really want to take levothyroxine for the rest of their life, and they don't want radiotoxicity, and they don't really want to have surgery. But the only thing is that there is kind of need for monitoring, and there is a relapse possibility, but this doesn't necessarily matter to them. They would rather just try it this way and hope for the best. Okay, so what about radioactive iodine? So factors that might predispose us to using this treatment, kind of same thing with the anti-thyroid drug, if they're at increased surgical risk. Big one is if they're planning pregnancy more than 6 months out, then we can definitely consider this therapy. Why can't we consider it if it's within that 6-month window? Well, I think radioactive iodine kind of speaks for itself. So we could also use this if there's contraindications to anti-thyroid drug use, so maybe they had a reaction to those. Also, this is another one where a rural patient might try to use this, and same sort of thing with the anti-thyroid drug where it might not be a good idea if they've already had neck surgery. A couple more contraindications with this, as you might expect since it's radioactive. So basically, if patients are pregnant or if they're lactating, as Roble likes to say, you want the baby to have a normal number of everything. You don't want the baby to be a mutant You don't want them to have 14 fingers and 12 toes. So that's kind of why that's this going on. Also, if patients have cancer, we don't want to worsen that or kind of mess with that. And if patients are unable to kind of meet the safety guidelines, and like we kind of talked about, contraindication if pregnancy is kind of more towards the forefront. Why might patients prefer this method? So patients might prefer this method because they have definitive control over the therapy. They don't want surgery, and they want to kind of have it in their hands. Patients like this don't care that it's going to take a while. They don't care about Graves' ophthalmopathy, and they really don't care that they're going to need to take levothyroxine for the rest of their life. They don't necessarily care too much about that. They would rather kind of have definitive control over what they're going to take. So thyroidectomy, so basically lopping out the thyroid. So factors behind why we might be predisposed to selecting this. Patient has large goiter, so if you really got that large thyroid gland, we might want to think about this therapy. Also might want to use this therapy if we suspect malignancy. And this is another big one that we can compare to the radioactive iodine. This one we can use if they're planning pregnancy less than 6 months out. So we can use it a little bit closer to pregnancy. We can also use it for patients like Rodney Dangerfield with moderate to severe active Graves' ophthalmopathy. And then this would be another factor as well. And then when we move into contraindications to this form of therapy, if patients really have substantial comorbidities, if it's not really worth the risk of the surgery, we shouldn't go through with it. And then when it comes to pregnancy, if they really need this surgery during pregnancy, we want to wait till after the first trimester when everything's developing and kind of moving and grooving. We want to try and do it at least in like the second trimester because that way things will just go a little bit better and we can have better access to anesthesia. Also important is we can't really do it if we aren't close to a physician that does this a lot. We don't just want to lump this on some rural physician that does this like 3 times a year. We want to have the physician that's doing this like 73 times a year. So as far as patient preferences go, so patients want definitive control, like the radioactive iodine, but they want it to be quick. They want to get that thing out of there. And they don't want to be bumping with radioactive stuff in their system. And they're okay with the surgical risk. And they're also okay with taking levo for the rest of their life. So that's thyroidectomy. Okay, so let's talk about the anti-thyroid drugs. And basically we're talking about the thioamides. So these guys work by inhibiting thyroid peroxidase, which basically looks to block thyroid hormone synthesis. So we don't really have that thyroid hormone running rampant. So really what we're hoping for is spontaneous remission, which happens in about 40 to 50% of patients. We're hoping that it'll basically resolve on its own. So this therapy isn't going to cure hyperthyroidism. There's 2 agents in the thioamide class that we use. Methimazole is pretty much the workhorse because it's daily. And it's 10 times as potent as PTU. So we pretty much use that one because, decreased toxicity, dosing convenience, there's a lot to like about methimazole. When we go to PTU, we have increased risk of adverse effects, especially hepatotoxicity. We have decreased dosing convenience because it's TID or QID, so that's not fun. But where we do like this one is that it's the drug of choice in the first trimester of pregnancy. So that's kind of where we see it kind of fall into line. So we could also use it in thyroid storm. That's another indication for it. And then when we talk about adverse effects with these agents, some more, I guess you would say, harmful ones to watch out for would be like agranulocytosis, aplastic anemia, hepatitis, and dermatitis. But those would be the adverse effects for these guys. So how do we dose the thioamides? So we want to look at FT4 when we dose these guys. So we want to know the upper limit of normal, so 1.8, and kind of go based on that. So if we're a little bit above, we want to do 5 to 10 milligrams a day, which is usually daily because that'll be easy. When we move down to 1.5 to 2 times the upper limit of normal, we're going to do 10 to 20 milligrams a day, and this can be either or. And then when we move into last category, 2 to 3 times the upper limit of normal, we're going to have to do 30 to 40 milligrams a day. And this is best done through BID dosing, so twice daily. And a big thing to know with this is know that treatment guideline for thioamide dosing, basically, how to adjust the therapy based on the levels and stuff like that. I didn't include it in this slide set because there's a lot of intermoving parts with it, and I felt that Rowold did a really good job of explaining it in his slides. So I would recommend that if you're confused about those treatment guidelines, really go back and hone in on those in his lecture slides, okay? And obviously I'd be free to take any questions if you guys have any. So moving to radioactive iodine. So there's a couple things to kind of keep in mind with this one. So this medication makes you hypothyroid, basically bumps you down there. So then you have to supplement it, and you have to supplement with levothyroxine, and this is usually for life. So that's just something to keep in mind. It's a relatively big dedication. Also, a big thing is that you really can't have contact with kids or pregnant women. So let's say the patient is, a father of 3 and there's another one on the way. Radioactive iodine probably isn't the therapy for him. Another thing is our key monitor of success with radioactive iodine is going to be free T4. And we want to monitor this every 4 to 6 weeks for 6 months while we're on therapy. So that's kind of the gist of radioactive iodine. So thyroidectomy. So there's this fancy little treatment timeline here that can be a little bit confusing to read, but we'll just kind of go through the finer points of this. So before a thyroidectomy, we want to start methimazole 6 to 8 weeks before the surgery. If, and you can look here, if that free FT4 is 2 to 3 times the upper limit of normal. We're also going to want to start iodide about 10 to 14 days prior to surgery. And then we also want to at least start the beta blocker at least 7 to 10 days before the procedure. So that would be propranolol. And then after the surgery, in a very broad sense, we're going to wean that beta blocker. We'll stop the methimazole on a taper, and then we will start levothyroxine because you need that supplementation, and we'll need to do that based on ideal body weight. So that's all I had for you guys. Obviously, it's not a exhaustive list of really everything that Rowold talked about, but I tried to kind of touch on the finer points and spend some time in greater detail kind of going through that stuff. So I wanted to highlight that there is a review session on Sunday, November 22nd at 10 in the morning. I know that might be a little early on the weekend for some people, but I encourage you to attend. We'll have practice questions for you. And we'll kind of work through those and touch on any points that are still a little bit confusing for you guys. I listed my email here in case you guys have any questions. And other than that, good luck studying.